aortic occlusive disease. So the aortic segment is very prone to atherosclerosis, and that can lead to a wide spectrum of symptoms. The guidelines for TASC C and D has been offering open surgery. However, some of these patients are not fit, and they can have endovascular intervention. Open surgery has been proved to provide a long-term outcome. However, that comes at the cost of early mortality and morbidity, which can reach up to 10%. Moreover, these patients are always have concomitant comorbid disease. Endovascular for aortic disease can provide an alternative. However, it comes at the cost of decreased primary patency rate. And a recent meta-analysis showed that the patency of endovascular at 5 years can range between 60 to 80%, whereas for open, it can reach up to 95%. So the ESVS in 2017 suggested that TASC C and D can be treated with endo first, provided that there is performed by experienced endovascular team, and that does not compromise the need for any future surgical intervention. Kissing stents have been used to treat aortic disease for a long time. However, in order to match the outcome of open surgery, different modalities have been used, and in this situation, using covered stents or bare metal stents. The idea of using a covered stent that the EPTFE will support the treated vessel, and at the same time, it will prevent the macrophages to migrate through the interstices, which can lead to inflammation and restenosis. However, this theory has not been established, and in the infrainguinal segment, the EPTFE stents has been found to have reintervention rate of up to 40%. So several studies have been performed, whether retrospective or RCTs, to look into the difference between covered balloon expandable stent and bare metal stents. In this retrospective study, they measured more than 240 limbs between 2006 and 2012. However, the majority of the patients were TASC A and B. They found that the bare metal stent have a better outcome in form of primary patency and secondary patency at 2 years compared to covered stents. However, the limb salvage was the same in both groups. Looking at the Kaplan-Meier graphs, there is a difference at 2 years concerning the primary patency and the secondary patency in favor of the bare metal stents. However, the COBUS trial, which is a landmark trial and the first RCT looking between covered balloon expandable stents and bare metal stents, they looked into this, and the difference here that half of the cases in the covered balloon expandable stents were TASC C and D. And they used the Advanta V12, and at the short term, at 18 months, they found that there is a significant difference in favor of covered balloon expandable stents in TASC C and D. However, there was no difference in TASC B. When they look into the long-term outcome at 18 months to 4 and 5 years, they found that there was significant difference in favor of the covered balloon expandable stents in the primary patency, the assisted primary patency. However, in the secondary patency, there was no difference, and it was up to 96% at 5 years. So all the difference was in TASC C and D. There was no difference in TASC B. And you can see at the Kaplan-Meier again, at 2 years and at 5 years, there was a significant difference. However, looking at TASC B and C and D, the difference was in TASC C and D, but not in TASC B. Another RCT was done, the Discover trial, which looked into 174 patients between 2012 and 2019. Again, the majority of the patients were TASC A and B, even 3/4 of the patients, and they used again the Advanta V12. At 2 years, they did not find any difference in the restenosis rate or the freedom from occlusion or the freedom from TLR between the two groups, the covered balloon expandable stent and the bare metal stents. So in this, at the restenosis, there was no difference. And again, at absence of TLR, there was no difference, and absence of occlusion, there was no difference. Another RCT that is currently recruiting is the Forward study. In this study, they are using the VBX, covered balloon expandable stent, versus either balloon expandable or self-expandable bare metal stent. The primary point will be primary patency at 1 year and multiple secondary points, and they are planning to follow up the cases for 5 years. Just a single case that I have treated recently, 70-year-old gentleman who presented with intermittent claudication at 100 yards. The patient had multiple endovascular intervention, including kissing iliac stents, and the duplex showed biphasic flow in the iliac arteries, however, with disturbed flow. And the angio showed that the kissing stents in the distal aorta were actually opposing each other rather than sitting next to each other. And you can see the lines of the stents, this one on the right and this one on the left. And it can be clear here that they are, rather than sitting next to each other, they are actually opposing each other. So we extended it proximally by putting covered stents, and you can see both stents are sitting at the same level. I saw the patient 10 days after the intervention, and actually he can walk for miles. So in conclusion, Mr. Chairman, ladies and gentlemen, the covered balloon expandable stents and the bare metal stents have similar results at task A or B, so you can use either. However, if the patient has task C or D, it is better to use covered balloon expandable stents because it provides a better mid and long-term outcome. The primary, assisted primary, and secondary patency rate can reach up to 90% at 1 and 1.5 years. And we are waiting again for another RCT to look into more insights and more results about these cases. Thank you.